Hello friends, I welcome you all to this important session of radiology for interns. I know many of you must be starting your internship and you will be, really excited to know how radiology actually supports your clinical practice. So in this whole session, I'll try to see that you get all the key concepts that you need to know about the imaging modalities that you have, the radiographs, the CT scan, MRI, ultrasound. We'll also understand some essential images that you all should know that will give you more confidence in your clinical practice. And do understand radiology is not just about image interpretation. It is also helping your patients find answers to their problems and also helps you make clinical decisions for your patients. So this is an important branch. You'll learn a lot about radiology in different departments, and my work here will be to give you a good insight that you can understand the radiology reports and the radiology images better when you're actively involved in your clinical work in internship. So let's get started and let's begin to the approach to radiology. The first thing that I want you to understand is the terminology. Remember, we have the four major modalities that you'll come across: the radiographs, the CT scan, the MRI, the ultrasound. On radiographs, anything that is white is called as radio opaque, and anything that is dark on radiographs is called as radiolucent. So when you're reading these radiology reports, radio opaque on an X-ray is basically white on X-ray. Radiolucent is dark on X-ray. On CT scan, the word for white is hyperdense. Please understand, hyper means white, hypo means dark. Hyper means white, hypo means dark. The word dense is used for CT. Hyperdense means white on CT, hypodense means dark on CT. Hyper intense is used in MRI. The word intense is used for MRI. Hyper intense is white on MRI. Hypo intense is dark on MRI. Hyper echoic, the word echo is used for ultrasound. Hyper echoic means white on ultrasound. Hypoechoic means dark on ultrasound. So when you go across these radiology reports during your internship and you get these terminology in your case sheets by your consultants, or when you're reading the radiology reports, understand these words. Where do we use dense? In CT. In MRI, intense. And in ultrasound, echoic. Hyper means white. Hypo means dark. Are we clear with this? And these terms are not interchangeable. Don't call it a radio opaque area on a CT scan. There is no radio opaque area on a CT scan. In a CT scan, there is hyperdense and hypodense only. So these terminology you should be clear with the diagnostic modality only. Now let's get started by understanding the chest radiographs. Now, when you're looking at the chest radiograph, start from an inside-out approach. Look at the center first. So in the center, you will be seeing the tracheal lucency. I hope you can identify the trachea. Also identify the bronchi, right? The right and left bronchi, the carina. Then see the hilum. The hilum is mainly formed by pulmonary artery. This is the hilum. The hilum is mainly formed by the pulmonary artery. A part of upper lobe pulmonary veins also, they form the hilum on chest radiograph. So identify these structures: the trachea, the bronchi, the bifurcation, the carina, and look at the hilum, the right hilum and the left hilum. Then look at the heart, the right heart border, the superior vena cava, the right atrium. So as the straight line here, this is the superior vena cava. Once it starts bulging out, that is the right atrium. Lower down, you see the inferior vena cava. On the left heart border, you're seeing the aortic knuckle, the pulmonary artery, the left auricle, and the left ventricle. So this is the aortic knuckle. Then you have the pulmonary artery, the left auricle, and the left ventricle. So this is your right heart border and left heart border. And only 1/3 of the heart is on the right side, 2/3 is on the left side. And in a normal chest radiograph, remember, the right hemidiaphragm is at a higher level than the left hemidiaphragm. This is because heart pushes the dome of diaphragm downward, not because of liver. It is not the liver pushing it upward, it is the heart pushing the dome of diaphragm downward. So right hemidiaphragm is usually a higher level than the left hemidiaphragm. If there is dextrocardia, the right hemidiaphragm will be at a lower level because it is the heart that pushes the dome of diaphragm downward, not the liver pushing it upward. So after you're done with this heart borders and the domes of diaphragm, do not forget to look under the domes of diaphragm. You will not see any air under right hemidiaphragm, but you will see air under the left hemidiaphragm. This is your gastric bubble that you have. Air under left hemidiaphragm is because of the gastric bubble. But if you see air under right hemidiaphragm, if you see air here, if you see air under the right hemidiaphragm, if you see air under right hemidiaphragm, this is suggestive of hollow viscous perforation. This is hollow viscous perforation or pneumoperitoneum. So it's very, very important to pick up the hollow viscous perforation or pneumoperitoneum in your patients. So don't forget to look under the domes of diaphragm also. Then when you're looking at your lung fields, look at the lung fields bilaterally symmetrically in different zones. Don't look at one lung completely and then see the other lung. Look at the lung fields bilaterally symmetrically in different zones. So the apical zones, so move your eyes from here to here. Then look at the upper zones, look at here, then look at here. Then the middle zones and the lower zones, right? So look at the lung zones bilaterally symmetrically in different zones to see that you understand how the chest radiograph appears. After that, I want you to look at the angles, the costophrenic and the cardiophrenic angles. So look at the costophrenic angle. So you may be seeing small effusions or you may see a paracardiac mass. So on both sides, look at the CP angles. Look at some retrocardiac area if you're finding any air fluid level that indicates hiatal hernia, right? So if you see a air fluid level on the posterior part, that indicates hiatal hernia. Look at the hilum again. Do not confuse whether it is a prominent hilum or a hilar mass there. Look at the lung apex again. You may be missing out on a Pancoast tumor or a tuberculous foci, right, which are in the apical regions. So look at these areas once again. So what are the review areas or hidden areas of chest X-ray? The CP angle, the retrocardiac area, the hilum and the lung apex. Look at them again so that you are more confident about it. Now let's start with understanding how to look at a chest radiograph. When you're looking at a chest radiograph, first begin by following an inside-out approach. Start from the center. Look at the trachea, look at the bronchi, right? Look at the carina. And the heart borders, the right heart border is formed by superior vena cava, the right atrium, and a part of the inferior vena cava. They form the right heart border. This straight line is the superior vena cava, and once it starts to bulge out, that is the right atrium. The left heart border is formed by the aortic knuckle, the pulmonary artery, the left auricle, and the left ventricle. So there is the aortic knuckle, the pulmonary artery, the main pulmonary artery, the left auricle, and the left ventricle. These form the left heart border. And remember, only 1/3 of the heart is on the right of vertebra, 2/3 is on the left of vertebra. And also remember to look at the hilum on the chest radiograph. So when you're looking at the hilum, remember the major part of the hilum on the chest radiograph is formed by the pulmonary artery. So this is the pulmonary artery. And also you have the upper lobe pulmonary veins, upper lobe pulmonary veins. So hilum on a chest radiograph is formed by pulmonary artery and also the upper lobe pulmonary veins. So look at the hilum carefully. Then look at the domes of diaphragm. You will see the domes of diaphragm as hemidiaphragm. This is the right hemidiaphragm, this is the left hemidiaphragm. And usually the right hemidiaphragm is at a higher level compared to the left hemidiaphragm. And the reason is not the liver pushing it upward. It is not the liver that pushes it upward. It is the heart that pushes the dome of diaphragm downward. So when you see any dextrocardia, the right hemidiaphragm will be at a lower level because it is the heart pushing the dome of diaphragm downward rather than the liver pushing it upward. Then look at the lung fields. When looking at the lung fields, don't look at the lung completely one side and then see the other lung. Always look at the lung bilaterally symmetrically in different lung zones. Look at the apical zones, compare this and then look at the other side. So always compare bilaterally symmetrically in different lung zones, the apical zones, the upper zones. These are imaginary zones, middle zones, lower zones. Compare bilaterally symmetrically. Keep moving your eyes bilaterally symmetrically in different zones so that you pick up any change in the lucencies better. So always compare bilateral lung fields in different zones. Then there are some hidden areas of chest radiograph I want you to look at. So do not miss out to look at the hidden areas of chest X-ray. The CP angles on both sides, the costophrenic and the cardiophrenic angle. Look at the retrocardiac area. Look at the hilum once again and look at the lung apex. These are called hidden areas or review areas of chest X-ray. You may be missing out on a small effusion there, blunting of CP angle. You may be seeing a small paracardiac mass. There could be a retrocardiac air fluid level in hiatal hernia patients. You may be confusing whether it is a hilar mass or a prominent pulmonary artery, or is it a hilar mass there. Or you may be missing a Pancoast tumor or a tuberculous foci in your patients behind the clavicle. So try to look at these areas again. These are your hidden areas or review areas of chest radiograph. Then look at the bones. When you look at the bones, this ribs, please remember the posterior rib is horizontal and the anterior rib is oblique. So when you're counting the ribs also, please be careful that you trace them properly, the posterior to anterior, the posterior to anterior. So the posterior ribs are horizontal and the anterior ribs are oblique. That is how you look at the ribs. So look at the clavicle, look at the scapula, look at the surrounding soft tissue, the breast tissue, right? You can see the breast shadow, the axillary area. So this is what is called as inside out approach. Let's do this once again. Whenever you hold a chest radiograph, look at the inside, look at the trachea. Is it displaced to any side? Is it displaced to the same side of the opacity or opposite side of the opacity? If there is a volume gain like a massive pneumothorax or a massive pleural effusion, the trachea will shift to opposite side. If there is volume loss like in collapse or atelectasis, the trachea shifts to same side. And in pneumonia or consolidation, there is no net change in volume, so there is no tracheal shift. So before you comment on the opacity, look at the trachea. Is the trachea in the midline or is it shifted to the same side or opposite side? Volume gain like pneumothorax, like pleural effusion, trachea shifts to opposite side. Volume loss like in collapse, the trachea shifts to same side, and there is no tracheal shift in pneumonia or consolidation. Also remember to look at the hilum, the heart borders, the domes of diaphragm. Do not forget to look under the domes of diaphragm. If you see under the left hemidiaphragm, you see the gastric bubble. If you see similar air under right hemidiaphragm, that is suggestive of hollow viscous perforation, hollow viscous perforation. So never forget to look under the domes of diaphragm. Then look at the lung fields bilaterally symmetrically. Look at the lung fields bilaterally symmetrically in different zones, the apical zones, the upper zones, middle zones, lower zones, and also look at the review areas of chest X-ray, the coastophrenic angle, the cardiophrenic angle, the hilum, the retrocardiac area, and the lung apex again. Look at the bones, the clavicle, the ribs, and remember the posterior ribs are horizontal and anterior ribs are oblique. By looking at the rib fracture, you should tell whether it is an anterior rib fracture or a posterior rib fracture. And also look at the surrounding soft tissues and the scapular region. So this is what is inside out approach to look at the radiograph properly. Let us look at some important examples. Now, if you do not look at the lung fields bilaterally symmetrically, if you're trying to only concentrate on one area, you will be confused. Maybe this is some kind of pneumonia and all. But if you see bilaterally symmetrically, if you compare bilaterally symmetrically, you know these are nothing but the breast shadows that you are seeing. So it is important to move your eyes bilaterally symmetrically in different lung zones. And never miss to look at the lung fields in the way I have told you. So if you can see here, look at this. Before you were seeing the radiograph, you are not concentrating well, you will miss this opacity. But if you follow the protocol, you look at the lung zones, apical zones, upper zones, middle zones, lower zones, and also try to look at the hidden areas of chest X-ray, you will pick up this lesion, this opacity that is in the right apical region. This is your Pancoast tumor, right, which can invade the brachial plexus, subclavian vessels. It can cause erosion of the rib, erosion of the clavicle there. So this is your apical lung opacity that you are seeing. Usually the Pancoast tumor would be there. Lung cancer, apical lung cancer. So this is how you have to look at the radiograph bilaterally symmetrically to pick up the pathologies better. A very common confusion we will have is when you are looking at the hilum. Is it a prominent pulmonary artery or is it a hilar mass there? So for that we have a sign called as hilum convergence sign. What it says that if you look at a prominent pulmonary artery or a prominent hilum, the adjacent vessels will be converging onto it. So if you track the adjacent vessels, if they are opening into this opacity here, this is a pulmonary artery. This is a pulmonary artery. But if you see opacity and the vessels are tracking medial to it, they are converging medial to it, this is a hilar mass. This is a hilar mass. So whenever you're confused, is it a prominent hilum there or is it a prominent pulmonary artery? Look at the adjacent blood vessels. Are they converging on it or are they converging medial to it? If they're converging on it, this is prominent hilum, the prominent pulmonary artery, prominent pulmonary artery, whereas if they are converging medial to the opacity, this is a hilar mass. It is also important to look whether it is a chest radiograph PA view, that is posterior view, or AP view, that is anteroposterior view. In the PA view of the chest radiograph, what you see is, because the patient is standing erect, PA view is the most common radiograph done, chest radiograph done. It is done in erect posture. Erect posture. The arms are abducted and taken in a full inspiration. So the most common chest radiograph taken is a chest X-ray PA view. It is done in erect posture with the arms abducted. Right, so when the whole patient is holding the film, the arms are abducted, so the scapula can move away from the lung fields. You can see the lung fields better. So when the patient is standing erect, obviously you will see the gastric bubble, and because the arms are abducted, the medial border of scapula will be more lateral. The medial border of scapula will be more lateral, and also you see the clavicles on the lung apex. So this is the lung apex; they are overlapping the lung apex. So that is how you have the PA view. The PA view will show you the gastric bubble, will show you the medial border of the scapula more laterally. You will see the clavicles overlying the lung apex. But in AP view, this AP view is done for patients of trauma. Patients in the ICU, supine patients, ventilated patients, lower limb fracture patients. So for these, we go for AP view, put the film behind, and the X-ray is taken from the anterior to posterior direction. AP view, because the patient is lying supine, you usually won't see the gastric bubble. And the medial border of scapula is more medial. The medial border of scapula is comparatively more medial, because the patient is supine, the scapula, medial border of scapula will be more medial. And if you look at the clavicle also, the clavicle will be above the lung apex. Remember, above, A for A, above the lung apex. They are on the lung apex, the clavicle is overlapping the lung apex in case of PA view, above the lung apex in AP view. So that is how we differentiate whether the radiograph taken is a PA view or a AP view. Now, why is it essential to know whether it is PA view or AP view? Is to understand whether you are seeing a cardiomegaly or a apparent cardiomegaly. Is this a cardiomegaly or apparent cardiomegaly? If it is an AP view, anteroposterior view, this is an apparent cardiomegaly. Anteroposterior view will cause the cardiac silhouette, the cardiac shadow to be enlarged. You will get an apparent cardiomegaly in a AP view. So to know whether it is actual cardiomegaly or a apparent cardiomegaly, you should know whether it is a PA view or AP view. Apparent cardiomegaly is seen in AP view. Apparent cardiomegaly, it appears to be enlarged, right? Not actually a cardiomegaly. And also, it is important to know whether it is an inspiratory film or expiratory film. In an inspiratory film, you will be able to see the ribs properly. You will be able to see at least 8 anterior ribs, 6 to 8 anterior ribs, or you may see about 10 posterior ribs. So this is a good full inspiration that you are having. If you see less than this, if you are seeing less than 6 or less than 10 posterior ribs, less than 6 anterior ribs, less than 10 posterior ribs, this is an expiratory film, and the lung volumes will appear small, so you cannot see the opacities properly here. So we would not like a expiratory film, we would want a inspiratory film. So we should know whether it is an inspiratory film or expiratory film. Expiratory film is usually repeated, so because you cannot comment on the lung pathology is better, the radiologist will ask you to repeat a chest radiograph when they see a expiratory film. They want a good inspiratory film, right? So this is difference between inspiratory and the expiratory film. It is also important to know whether you are looking at a inspiratory view or a expiratory view. The inspiratory view will show you the ribs properly. You will see at least 6 to 8 anterior ribs or 8 to 10 posterior ribs in a good inspiration. When you are inspiring well, you will see the lung fields properly, and you will see about 6 to 8 anterior ribs or 8 to 10 posterior ribs. But if you see less than these, less than 6 anterior ribs, less than 8 posterior ribs, you are looking at an expiratory film. In expiratory film, obviously the lung volumes are small, you will not see the pathologies better. So it is important to take the radiographs in an inspiratory view. You will see that the expiratory radiographs are being repeated because the radiologist cannot comment on the expiratory film. He will advise you to repeat a chest radiograph when he sees an expiratory film. And also remember how the exposure of the film is. If the film appears whitish, this is a underexposed film. This is underexposed. If it is more dark, this is overexposed. This is an optimal chest radiograph, optimal exposure. So if the film is appearing more whitish to you, it is an underexposed film. If it is appearing very black to you, it is an overexposed film. right? So you should just get an idea whether it is an underexposed film or is it an optimal exposure or overexposure. And let us look at some tubes and lines that you see on a chest radiograph routinely in practice. This tube that you see within the trachea, this is your endotracheal tube. The endotracheal tube, the tip of the endotracheal tube should be at least more than 5 centimeters from the carina for aerating both the lungs properly. If the tip of the endotracheal tube is gone into one of the main bronchus, only that lung will get aerated. There may be a faulty insertion sometimes, aerating only one lung. So look at the tip of the endotracheal tube. The tip of the endotracheal tube normally should be more than 5 centimeters from the carina. And what is this line that you are seeing here? I can zoom it for you. Can you see this line that is coming into the suprapubic cava? So this is your central line insertion. This is the central line. From the neck region, you can see this line entering into the suprapubic cava. This is your central line that you see in your patients. And what is this image showing you? This is the insertion of a normal nasogastric tube. This is the nasogastric tube that you are seeing entering into the stomach. Whereas here, there is coiling of nasogastric tube in an infant. Coiling of nasogastric tube. So where you see such coiling of nasogastric tube, a newborn with frothing and coiling of nasogastric tube, think of tracheoesophageal fistula, tracheoesophageal fistula. What is this tube that you see on the radiographs? This is your intercostal drain, ICD. And what is this tube that you are seeing? This is your tracheostomy tube. This is the tracheostomy, right? So these are different tubes that I want you to keep in mind, they routinely see on the radiographs. And what is this? Please remember, these are your ECG leads. These are your ECG leads. And this is a cardiac pacemaker in the patient. Cardiac pacemaker has these two thin electrodes, one ending in the right atrium and one ending in the right ventricle. So cardiac pacemaker has these two thin electrodes, one ending in the right atrium and one ending in the right ventricle. This is your cardiac pacemaker. So do not confuse with the ECG leads, the cardiac pacemaker, okay, and then the central line, the nasogastric tube, all these things you may see on the radiographs. And what is this on the chest radiograph that you are seeing? These are your sternal sutures, right? So if the patient must have undergone any cardiac surgery, sternotomy done, right? So you are seeing those sternal sutures. And what is this in the heart? This is a prosthetic mitral valve. This is a prosthetic mitral valve. So if you draw an imaginary line from the left hilum to the right cardiophrenic angle, from the left hilum to right cardiophrenic angle, this is what is a imaginary line that is drawn from the left hilum to right cardiophrenic angle. If the valve is located below it, this is a prosthetic mitral valve. And if the valve is located above it, this is the aortic valve. So whenever you want to know what type of prosthetic heart valve is it a prosthetic mitral valve or a prosthetic aortic valve, draw an imaginary line just below the left hilum, from the left auricle area, from the area of the left auricle to the right cardiophrenic angle. Just below the left hilum, you draw the line from the left auricle to the right cardiophrenic angle. If you see the valve below this, this is your mitral valve, and if you see the valve above it, that will be the aortic valve. So mitral valve will be below it and aortic valve will be above this imaginary line. And also it is important to look at your lateral radiographs. So when you look at the lateral radiographs, remember this is your minor fissure and here like this will be your major fissure. So once you know this is the minor and the major fissure, you know the middle lobe will be corresponding to the cardiac shadow, will be exactly corresponding or overlapping the cardiac shadow. And above this will be the upper lobe and below this will be the lower lobe. So understand the minor fissure and the major fissure and you can understand the upper lobe and the lower lobe. Remember the middle lobe overlaps the cardiac shadow, middle lobe overlaps the cardiac shadow. And also how to know whether it is a middle lobe pathology or a lower lobe pathology on the frontal radiograph. On a lateral radiograph I taught you, it will be overlapping the cardiac shadow. This is the minor fissure and here will be the major fissure like this. This is the major fissure. So you have an upper lobe, you have a middle lobe and a lower lobe. But how do you differentiate, is it middle lobe or lower lobe on a frontal radiograph? You have to look at the heart border. If there is an opacity in close contact with right heart border, obscuring the right heart border, in close contact with right heart border, that is your middle lobe. Middle lobe is in close contact with the right heart border. It overlaps the cardiac shadow on the lateral radiograph. And if you see a opacity which is overlapping the hemidiaphragm, that is a lower lobe pathology. So if you see a pathology in close contact to right heart border, that is a right middle lobe pathology. If you see a pathology in close contact with the hemidiaphragm, that is your lower lobe pathology. So look at this image. Now what do you think is this? Is it a right lower lobe pathology or right middle lobe pathology? Look at the pathology. It is in close contact with right heart border. So if it is in close contact with right heart border, this is right middle lobe pathology. Right middle lobe is in close contact with right heart border, and it overlaps the cardiac shadow on the lateral radiographs. And look at this. Where do you think is the pathology in this radiograph? In this radiograph, you can see that the pathology is obscuring the hemidiaphragm. It is obscuring the hemidiaphragm. So this will be a lower lobe pathology, right lower lobe pathology. So how to know whether it is a lower lobe or a middle lobe pathology on a frontal radiograph? Look whether the pathology is obscuring the right heart border or is it obscuring the hemidiaphragm. It is obscuring the right heart border, it is middle lobe pathology. If it is obscuring the hemidiaphragms, it is a lower lobe pathology. Now, let's look at some important chest radiographs. The first one we look at is how to identify pneumonia on a chest radiograph. So in pneumonia, there is no tracheal shift. There is no tracheal shift. And in pneumonia, there are very ill-defined fluffy borders. Ill-defined fluffy borders. So when there is no tracheal shift and you see the opacity which is ill-defined with fluffy borders, this is your pneumonia or consolidation. Let me show you another example. So look at here. You can see this all ill-defined fluffy borders and there is no tracheal shift. And you can see the air bronchograms. You can see the air bronchogram. These are called air bronchograms. You can see the air bronchograms. So you can see the air-filled bronchi, the black bronchi in the opacity. So these are your air-filled bronchograms. So when you have alveolar opacities but air inside the bronchus is intact, when you have alveolar opacities with air inside the bronchus intact, this leads to air bronchogram. So this is how you see the pneumonia or consolidations. Ill-defined fluffy borders, no tracheal shift, presence of air bronchogram through the opacities. All of this tells you this is pneumonia or consolidation. And look at this image. Is the opacity homogeneous or heterogeneous? So if you see this opacity here, it's a very heterogeneous opacity with some cavitations, right? You can see some cavitations from fibrotic strands. So such heterogeneous opacities on the radiograph with cavitations, upper lobe involvement usually, all of these should make you think of tuberculosis. Heterogeneous opacities, cavitations, upper lobe involvements, this should make you think of tuberculous bacilli. What is this chest radiograph showing you? I hope you can see in this chest radiograph, there is obliteration of CP angle. There is a meniscus-like area and a concave upward curve. This is the meniscus sign and this is the Ellis curve that you're having. So if you see obliteration of CP angle, you are seeing meniscus sign of the opacity. So it is not ill-defined or fluffy. You are seeing a sharp meniscus-like area and a Ellis curve. Ellis curve is a concave upward curve that you're having. This tells you this is pleural effusion. So the first area where the pleural fluid will collect is in the costophrenic angle. So if you see obliteration of CP angle, a meniscus and a Ellis curve, this is pleural effusion. Now look at this chest radiograph. What do you see here? You can see the trachea. I asked you to start from the trachea. The trachea is shifted to the same side. So the trachea is shifted to the side of opacity. And if you look at the bronchus is cut off here. You can see the bronchus only till here. From here, you are not seeing any air bronchograms. There is a bronchial cutoff. And compare the ribs here on the side of the lesion. So you can see that in the left hemithorax, the ribs are appearing to be crowded. They're all close by compared to the right side. The left side, the ribs are appearing to be very close by. There is crowding of ribs. So when you see bronchial cutoff, trachea shifted to same side, there is crowding of ribs. All of these indicate volume loss. Okay, so this is suggestive of a lung collapse. And if it is a lobar collapse, it's a upper lobe collapse, middle lobe collapse and all, you will have a sharp margin. Collapse will have sharp margin. And pneumonia or consolidations will have ill-defined fluffy margin. is it a right upper lobe collapse or is it a right upper lobe pneumonia? If the margins are ill-defined and fluffy, that is right upper lobe pneumonia. If the margins are sharp, that would be the right upper lobe collapse. So to know whether it is collapse or whether it is pneumonia, look at the margins. Ill-defined fluffy margins is pneumonia or consolidation. And if you see sharp margins, think of collapse. Another clue is try to look at the opacity better. If you see carefully, if you are able to see branching bronchi, air-filled bronchi, that is suggestive of pneumonia. How do you differentiate a lobar collapse from a lobar pneumonia? Remember, in lobar collapse, there will be a sharp margin, whereas in pneumonia, you have ill-defined fluffy margins. In collapse, you will see bronchial cutoff. You will see the bronchia cutoff. You will not see any air bronchograms in collapse. Whereas air bronchogram, the air-filled bronchi may be seen, the branching bronchi may be seen in the opacity in case of pneumonia or consolidation. Please remember, air bronchogram are seen in pneumonia or consolidation. Bronchial cutoff is seen in collapse. Ill-defined fluffy borders are seen in pneumonia. Sharp borders, sharp margins are seen in collapse. Right? So you tell me, what is this? Is it a right upper lobe collapse or a right upper lobe pneumonia here? So if you see the image carefully, you will see that there are sharp margins. And look at the trachea is also slightly tilted to the right side. So this is a right upper lobe collapse, right upper lobe collapse. And I am not seeing any kind of bronchi also. So this is your right upper lobe collapse. Now look at this image, what comes to your mind? On this chest radiograph, you are seeing there is right upper lobe collapse, there is a sharp margin. But trace the margin carefully, you are seeing a reverse S. This is called as golden S sign or reverse S sign. Golden S sign or reverse S sign should make you think of underlying bronchogenic carcinoma. So please remember, this is suggestive of bronchogenic carcinoma with right upper lobe collapse, right upper lobe collapse. So basically what happens is when you have a mass, it pushes the lower part of the fissure outward, and the collapse of the right upper lobe because of the mass will cause the fissure to move inward. So it's actually a reverse S sign. So the mass, there is a mass here that is pushing the lower part of the fissure outward, and the associated right upper lobe collapse is causing the fissure to move inward, producing a reverse S-like area. A reverse S sign or golden S sign is suggestive of bronchogenic carcinoma with right upper lobe collapse. So you see a smoker, weight loss, right, and you see this radiograph. This is not pneumonia or collapse. This is suggestive of bronchogenic carcinoma, the reverse S sign or the golden S sign. Now look at this important chest radiograph. What comes to your mind? So when you see a trauma case who is having absent bronchovascular marking, these are your bronchovascular marking. These white lines are your bronchovascular marking. You are seeing absent bronchovascular marking, visceral pleural line, the lung being collapsed towards the hilum. You will see a deeper sulcus compared to the normal side, especially when the patient is supine, right? In case of pneumothorax, you will see a deeper sulcus. So there are the three findings that you see in pneumothorax. On a chest radiograph, when you compare the lung fields bilaterally symmetrically, you see a more lucent area there, which is not having any bronchovascular marking. You'll also see a visceral pleural reflection and a deep sulcus sign. Deep sulcus appearance, compare the both costophrenic sulcus, the side of pneumothorax will have more deeper sulcus. So let me show you on a CT scan, it's much easier to appreciate that. So absent bronchovascular marking, these are your bronchovascular marking. Absent bronchovascular marking, deeper sulcus compared to the normal side, and also the visceral pleural line. So this is the sulcus here and this is the sulcus here. You can see there is a deeper sulcus. So see the sulcus here, see the sulcus here. This will be much deeper compared to the normal side. So this normal side, this is the side of pneumothorax. A deep sulcus sign, visceral pleural line, these are suggestive of pneumothorax. And what is this chest radiograph showing you? This is also an important emergency. You should not miss out. A pain abdomen patient with rigidity, and you are seeing air under right hemidiaphragm. Never forget to look air under the right hemidiaphragm. Always look under the domes of diaphragm. Never forget to look under the domes of diaphragm. This is suggestive of hollow viscous perforation. Hollow viscous perforation or pneumoperitoneum, right? Hollow viscous perforation, pneumoperitoneum. We get a chest radiograph done. Whenever you are suspecting a hollow viscous perforation or pneumoperitoneum, we go for a chest radiograph. The domes of diaphragm are better seen on a chest radiograph. Air under right hemidiaphragm is suggestive of hollow viscous perforation. And this is how pleural effusion would appear. You will see obliteration of CP angle, meniscus sign and Ellis curve, And when you go in a lateral decubitus view, you will see this layering of a free-flowing effusion. So you see that layering in a lateral decubitus view. The best X-ray view to look at small pleural effusions is a lateral decubitus view. So in the X-ray, if you want to see the pleural fluid better, you will use a lateral decubitus view. Frontal radiograph will need about 150 to 200 ml of fluid to be seen on a chest radiograph, pleural effusion, to cause obliteration of CP angle. To be able to pick up pleural effusion on a frontal radiograph, you need about 150 to 200 ml. Whereas lateral decubitus view can pick up around 10 to 15 ml also. So such good radiograph, that is lateral decubitus view, to pick up small effusions. Less than that you want to see, you can go for ultrasound, right? So please remember, and it is lateral decubitus. The patient is on the stretcher and turning to one side. It is not lateral view. Lateral view is different. The patient is standing and turning to one side. That is lateral view. Lateral view will pick up about 75 ml of fluid. So it is a lateral decubitus. He should be on the stretcher and turning to one side. You put the film and you take a horizontal beam of X-rays through him. So the patient is turning to one side, the side of effusion. If he's right pleural effusion, you will ask him to on the bed. He's lying on the bed and turning to right side. You're putting the film behind, and the X-ray is not taken vertically. The X-ray is given a horizontal beam of X-ray. This is what is your lateral decubitus view. Best X-ray view to look at pleural effusion. Now look at this radiograph. You can see that the trachea is shifted to the opposite side, and you are seeing a large opacity in the left hemithorax. This is what is a massive effusion that can cause trachea shifted to opposite side, the heart shifted to opposite side. This could be a case of volume gain, that is massive pleural effusion. And for pleural effusion, to know what is the cause of pleural effusion, is it any underlying malignancy there, a lung cancer causing hemorrhagic effusion, or is it a tuberculosis foci there? Always, whenever you see pleural effusion, evaluate it with a CT scan to know the cause of effusion. Is it any underlying mass, or is it tuberculosis that is causing it? And what is this D-shaped collection that you are seeing? D-shape, broad base towards pleura, attached to the pleura. And even if you put on a lateral decubitus view, does not change position. So D-shape, broad base towards pleura, and no change in position. So even on going on a lateral decubitus view, it does not change position. This is suggestive of loculated effusion. Loculated effusion. So because of multiple septations and locules, even the patient is turning, it is not changing position. And even if it is difficult to aspirate on ultrasound guidance also, because so many locules and septations, very difficult to aspirate also, this is how loculated effusion will appear. And if you have a congestive heart failure patient with cardiomegaly, basal congestions, effusions, and you are seeing a lentiform collection along the figural lines. So you are seeing a lentiform collection along the fissures between the right upper lobe, middle lobe, lower lobe, like that. Between the fissures that you are seeing, this is a interlobar effusion. Interlobar effusion, also called as phantom tumor. It appears like a tumor but disappears on diuretics. It appears like a tumor, but once you give diuretics, it goes away. It's basically a fluid collection there. This is interlobar, as the name says, between the lobes. Interlobar effusion. This is how the interlobar effusion will be there. They will be associated the fissural collection, that is interlobar effusion or phantom tumor. And what is this image showing you? In this image, you can see a horizontal air fluid level. So you can see this is the air and this is the fluid part, and you are seeing a horizontal air fluid level. Such horizontal air fluid level, this is suggestive of hydropneumothorax. So horizontal air fluid level, if you are seeing, that is hydropneumothorax. Pleural effusion would show meniscus sign and Ellis curve. A horizontal air fluid level, think of hydropneumothorax. And if you see collections in the pleura after trauma, if you are seeing collections, right, a stab injury or a road traffic accident, and you are seeing collections in the hemithorax, also think of hemothorax in your patients, right? So please remember, pleural effusion would show you meniscus sign, a hydropneumothorax will show you horizontal air fluid level, and if it is associated with trauma, think of hemothorax also. Now look at this chest radiographs. This is a fever patient with bilateral reticular opacities in lung fields, dry cough in the patient, and he is having bilateral reticular opacities, network-like lines, bilaterally in the lung fields. This is suggestive of interstitial pneumonia. interstitial pneumonia, viral pneumonias, right? The viral pneumonias, mycoplasma, legionella, these are interstitial pneumonias. They show bilateral lung field showing reticular opacities. And if you see small seed-like opacities, millet seed-like opacities, small opacities, bilateral in diffuse lung fields, think of miliary TB, right? So miliary TB. Both of them are fever patient. Both of them have cough, fever. Then how do you differentiate? Both of them have bilateral lung field involvement. Is this network like lines, reticular lines, or is this dots? So the difference is lines or dots. So if you see reticular opacities in the lung fields, that is what is interstitial pneumonia. And if you like see dot-like opacities in bilateral lung fields, that is suggestive of miliary TB, right? So please be careful, it is the lines or dots. Look at this chest radiograph in an elderly smoker. What do you find? Here you can see there is flattening of domes of diaphragm, there is widening of intercostal space, and on a lateral radiograph you see a increase in retrosternal space. This is sternum and this is heart, and this is increased, talking about hyperinflated lung fields. So you are having hyperinflated lung fields, more than 8 anterior ribs, more than 10 posterior ribs, flattening of domes of diaphragm. You are seeing increased retrosternal space. All of this is emphysema or COPD. Emphysema or COPD patients, right? And if you see large opacities, cannonball opacities in bilateral lung fields, this cannonball opacities, this is pulmonary metastasis. And if you see a thick walled cyst with horizontal air fluid level, a thick walled cyst with horizontal air fluid level in it, right? Not in the pleura, but within the lung cyst, you are seeing this thick walled cyst with horizontal air fluid level. This is suggestive of a lung abscess, a fever patient with a thick cavity, a thick walled cyst with air fluid level. Think of lung abscess. And if you see multiple grouped opacities in the perihilar region, this is what is pulmonary edema. Pulmonary edema, giving a classic bat wing-like opacities. So these are perihilar opacities. Perihilar opacities, confluent opacities in the perihilar region giving a bat wing configuration. Think of pulmonary edema. MI patients, congestive heart failure patients, when you see such radiograph, think in lines of pulmonary edema. And when you see cardiomegaly, basal congestion, you see prominence of upper lobe vessels. You see the upper lobe vessels more prominent. This is called cephalization. Cephalization. Think of congestive heart failure. The earliest finding in congestive heart failure is the prominence of upper lobe vessels. There is prominence of upper lobe vessels. This is congestive heart failure. And you may see interstitial septal thickenings. Okay, you may see sometimes thin horizontal lines parallel to each other, perpendicular to pleura, right, at the base of the lung. This is called as curly B lines, curly B lines. And if you see thin lines in the perihilar region, these are your curly A lines. So these are interstitial septal thickenings, curly B lines and curly A lines. They occur in the interstitial phase of congestive heart failure, right? And you see these curly B lines at the base, B for B, base of the lung, and curly A lines are in the perihilar region. These are interstitial septal thickening occurring in congestive heart failure. And if you see a trauma patient and you see along the subcutaneous planes these lucencies, these radiating lucencies, can you see these black lines here like this? These radiating lucencies in the subcutaneous planes, right? So here also you can see all these black lines. This is suggestive of subcutaneous emphysema. Trauma patient, and you see this black lucencies in the subcutaneous planes. Think of subcutaneous emphysema. Now this is an important clinical scenario. When you have a child between 2 to 3 years age group generally, this is a child when he is able to move and explore things, and independently of the mother he is moving and playing around in the room. So this is a 2-3-year-old child who's developed sudden onset of respiratory distress. Sudden onset of respiratory distress. He was fine but suddenly developed respiratory distress. And when you take a chest radiograph, if I compare the lung fields, I can see there is a lucent hemithorax on the left side. So you may get a lucent hemithorax. Lucent hemithorax. Or sometimes when I compare the lung fields, a same 2 to 3-year-old child, sudden onset of respiratory distress. When I'm comparing the lung fields, there is a opaque hemithorax. Either you get a opaque hemithorax or a lucent hemithorax. In a 2 to 3-year-old child with sudden onset of respiratory distress, either you get lucent hemithorax or opaque hemithorax. Strongly suspect foreign body. Strongly suspect foreign body. So foreign body, imagine the foreign body is completely blocking the bronchus. This will cause lung collapse and a opaque hemithorax. But if the foreign body is causing a ball-valve mechanism, allowing the air to come in, not allowing it to go out. It is allowing the air to come in but not allowing to go out. There is air trapping in expiration. There is air trapping occurring in expiration. So you see a lucent hemithorax. So either you see a lucent hemithorax or a opaque hemithorax in a child between 2 to 3 years age group. Strongly suspects foreign body. When it develops a sudden onset of respiratory distress, you take the radiographs, please suspect foreign body. Now look at this. This is a 2-year-old child with sudden onset of respiratory distress. Inspiratory and expiratory phlegm is given to you. So here we have taken a inspiratory phlegm and this is a expiratory phlegm. Now where do you think is the foreign body? Is it in the right lung or in the left lung or in the esophagus? Where is the foreign body? A 2-year-old child, sudden onset of respiratory distress, a inspiratory and expiratory phlegm is given. So if you look carefully, in inspiration the lungs will be big, in expiration the lung will be small. Inspiration the lung will be big and the expiration the lung will be small. So the right lung is big in inspiration, small in expiration. This is normal. But if you look at the left lung, look at in inspiration it is big, but look at expiration, again it is big. It is not collapsing, it is not becoming smaller, it is appearing same. So there is air trapping in the expiratory phlegm. That means there is a foreign body in the left bronchus. Okay, so this is causing air trapping in the left lung. This is suggestive of a foreign body in the left side. So do not confuse with these ECG leads. These are your ECG leads. These are your ECG leads. These are not foreign bodies, right? So there is not a foreign body in the right lung. There is a ECG lead. There is a lucent hemithorax. If you compare the right and the left lung, I hope you can see there is a lucent hemithorax and there is air trapping in expiratory phlegm. So when you see air trapping, when we see air trapping in expiratory phlegm, think of foreign body. Think of foreign body. Okay, so important to understand this. Let us look at some important abdominal radiographs. When you see bubble loops which are distended one above the other, giving a step ladder pattern, and these are central bowel loops, these are in the center, think of small bowel obstruction, small bowel obstruction. And if you see the bowel loop carefully, you are able to see these mucosal, circular mucosal folds running through and through the bowel wall. These are called as your plica circularis or valvulae conniventis. So plica circularis or valvulae conniventis in the small bowel obstruction, this indicate these are jejunal loops, jejunal obstruction. So when you have jejunal obstruction, you will see the jejunal loops with plica circularis or valvulae conniventis. These are central in location. But if you see peripheral loops, distended peripheral loops, there is no much, plica circularis and all. Instead, you see haustration, you see haustra. These are large bowel obstruction. So peripheral loops, presence of haustration, these tell you this is large bowel obstruction. And this is important, I hope you all know this. This is coffee bean sign. Coffee bean sign. This is suggestive of sigmoid volvulus. Sigmoid volvulus. So the coffee bean sign, where you see these two loops and a cleft in between. So this is your coffee bean sign that you see in sigmoid volvulus. So with this, we complete some important chest radiographs. I have covered you some important emergency abdominal radiographs, how to look at intestinal obstruction, small bowel obstruction, large bowel obstruction, sigmoid volvulus, and how to identify the hollow viscous perforation or pneumoperitoneum when you see air under the right hemidiaphragm. Now let's look at some CT scan images. Now when you are looking at a CT scan image, it is important to get the orientation right. So please remember, the bones are white on a CT scan. So whenever you see the bones are white, that is CT. The bones are white and the subcutaneous fat is dark. So the bones are white, the cortical bone, this is white, and the fat is dark or hypodense on CT scan. Opposite is true on MRI. The bones are dark and the subcutaneous fat is white on MRI, whereas bones are white and the fat is black on a CT scan. So that is how I know this is CT or MRI. And whenever you see any axial section, please remember this is the right side, this is the left side, this is the anterior part, this is the posterior part of the patient. So whenever you're looking at the CT scan, do not confuse right side, left side. Imagine that the patient is lying down with his legs facing you, and you are standing at the foot end of the patient, and you're cutting him slice by slice. So whenever I see any axial CT or axial MRI, I always imagine that the patient is lying down with his legs facing me. I am standing at the foot end of the patient. Imagine this. Imagine I am lying down with my legs facing you. You are standing at the foot end of the patient, and you are cutting me slice by slice. This will be the right side, this will be the left side. This will be the anterior part, this will be the posterior part. So you know which is the right kidney, right epidural left epidural right orbit, left orbit. So always imagine that way, that the patient is lying down with the legs facing you. So whenever you hold any CT scan, right, in any direction, always keep this orientation in your mind. The patient is lying down with the legs facing you. You are standing at the foot end of the patient and cutting him slice by slice. So right side, left side, anterior part, posterior part. And then please understand, this outer part is a gray matter and the inner part is a white matter. So the slightly darker one is a white matter, the grayish part is a gray matter. And this gray matter abutting the frontal horn of lateral ventricle is your caudate nucleus. This slit-like area is a third ventricle. On either side of the third ventricle, you see the thalamus. And this here is the lentiform nucleus. This gray matter is the lentiform nucleus having an outer putamen and inner globus pallidus. They have outer putamen and inner globus pallidus. And the white matter bundle, this dark lines that you are seeing, between the caudate nucleus and the lentiform nucleus, this is your anterior limb of ventral capsule. This white matter bundle between the lentiform nucleus and thalamus, this is the posterior limb of ventral capsule. This black sulcus that you are seeing, this is your sylvian fissure on either side that you are seeing, this large one, this is your sylvian fissure or the lateral sulcus. This fold of dura here, this is the falx cerebri. The falx cerebri, the fold of dura separating the two cerebral hemispheres. And can you see this soft tissue calcification just posterior to third ventricle? Just posterior to third ventricle, we have the pineal gland. So pineal gland is normally calcified. Even young children, when you do CT scan, you see this calcification on the pineal gland. It's a normal site of calcification. Another normal site of calcification are your choroid plexus. The choroid plexus are located within the occipital horns of lateral ventricle. These are the frontal horns, these are the occipital horns of lateral ventricle. Within the occipital horns of lateral ventricle, you see calcifications of the choroid plexus. These are very common calcifications, common sites of calcification. These are normal calcification, normal CT scan. This is not some hemorrhage or bleed or stuff like that. Do not confuse with them. Even young children have these calcifications on their CT scan. The pineal gland and choroid plexus, these are normal sites of calcification on a CT scan. So don't confuse it with some pathology or some hemorrhage there. It's normal sites of calcification, the pineal gland and the choroid plexus. And also remember, when you're looking at the CT scan images, you have to see which window you are seeing. So when you see the CT scan console, when you press this, you get drop down, showing you different windows: bone window to see the fractures, brain window to see the brain parenchyma, mediastinal window to look at the blood vessels and the lungs and the heart, and a lung window to look at the lungs. So you have these four windows: bone, brain, mediastinal window and the lung window. So to look at what structure you want to see, you will change the settings. If you are trying to look at the fractures, you will go to bone window. If you want to see the heart and the blood vessels, you go for mediastinal window. When you want to look at the lung parenchyma, COVID, pneumothorax you want to see, you will go for lung window. So these are settings that you have. So this is how the lung window will appear. Your heart is obscured, your bones are not seen properly, but the lung parenchyma, the bronchoscapular markings are seen clearly in a lung window. But when I go to mediastinal window, the lungs are obscured, but I can see the heart, the blood vessels better. So in a mediastinal window. So I change the settings based on what I want to see, whether I want to see the mediastinal structures or do I want to see the lung parenchyma. This is the windows in the CT scan. Remember, when you are looking at CT scan, you have these sagittal, coronal and axial sections given to you. This is your sagittal CT scan, the bones are white, and on this you can see the paranasal sinuses. So you are seeing the frontal sinus in the frontal bone, these are your ethmoidal sinus, this is the sphenoid, this is the sella, right? This is the clivus, this is the C1 vertebra, this is the dens of the C2 vertebra. So this is how you have your CT scan showing the different structures here. This is your normal frontal sinus. They are normal air filled. These are normal maxillary sinus. This is the nasal septum. This is the turbinate, right? The inferior turbinate. And you are also seeing the maxillary antrum. These are your right and left maxillary antrum. So they are normal air filled. This is the mastoid air cell. This is a normal mastoid, air filled. But look at the left side, there is soft tissue attenuation. There is a soft tissue collection. I can't see the black area there. It's all soft tissue, density there. So when you see such soft tissue density involving the mastoid air cells, this is suggestive of mastoiditis. Mastoiditis. A similar soft tissue collection in the maxillary sinuses would tell me that it is maxillary sinusitis. In the frontal sinus would tell me it is frontal sinusitis. So normally they should be dark, air filled. But if you see soft tissue collections, right, and mucosal thickenings, you get that suggestion that this is mastoiditis, sinusitis in your patients. So normally they should be dark. And when looking at a CT scan, you should have the orientation right. These are sections that you are seeing. From different levels, you are seeing these sections. So if you see the sections in the CT scan, you are seeing this is the higher level. You are seeing the body of ventricles, and as you go down, you will see the frontal horn, occipital horns, and finally you are seeing the basal ganglia structures, and as you go more down, you will see the fourth ventricle and all. So don't expect to see everything in every slice based on where you are. So if you are taking from the very higher level, you will only see high parietal area, no ventricle. Then you will see body of ventricle, then the frontal horn and occipital horns of lateral ventricle, and as you go down posteriorly, you will see the fourth ventricle. So based on how the section is going, you will see. So do not consider this to be the higher level, right? Because you are seeing the third ventricle, the occipital horn, and here you are just seeing the body of ventricle. So this is at a higher level. So while looking at the images, you should know which section you are in. By understanding the ventricles, by understanding different levels, right? You need to understand. One more example I'll tell you. Imagine this is the arch of aorta. This is the ascending arch and the descending aorta. You have the three vessels from the arch of aorta. The brachiocephalic artery, left common carotid, left subclavian. If I take a section here, I will only see these three vessels on the CT scan. So imagine I'm doing the CT scan. This is the vertebra and the sternum, right? I will see these three vessels. But if I take a section here, right side, this is right side, this is left side. The patient is lying down with his legs facing you, right? You are standing at the foot end of the patient. So don't confuse right side, left side. So on the right side, this is brachiocephalic artery, the next left common carotid, left subclavian. If I take a section from here, so imagine this is the sternum, this is the vertebra, I will see the arching of aorta at that time. If I take a section from here, so imagine this is the sternum, this is the vertebra. Anteriorly, I will see the ascending aorta. Posteriorly, I will see the descending aorta. And we all know right and left brachiocephalic vein unite and form the superior vena cava. And the main pulmonary artery divides into right and left pulmonary artery. So imagine this is the ascending aorta you are looking at. To the right of ascending aorta, what vessel will you see? Superior vena cava. To the left of ascending aorta, what vessel you see? Main pulmonary artery. Main pulmonary artery. So if you take a section there, towards the right, you will see the superior vena cava. Towards the left, you will see the main pulmonary artery dividing into right and left branches. So this is how the sections will appear. So initially you will see the branching of the arch of aorta. Then you will see the arch of aorta. Then you will see the ascending and the descending aorta. Don't expect to see everything in every slice. Okay, please understand where you are in the body, and that is how the images will start appearing. So imagine one more thing. Imagine this is the liver. If I take a section here, I will see the full liver. But if I take a section here, the liver will appear small. So this is still liver, right? But it is taken from the lower part of the liver. So that is how, look at the small area on the right side and think it is spleen. On the right side, it is liver. not spleen. Okay, so please understand how these sections are taken and how you should be able to interpret the images. Some important CT scan images that all of us should know. Please look at this. This is a trauma case, and you are seeing a hyperdense collection limited by the sutures. Okay, limited by the sutures. This is right epidural hematoma, and you can see some hypodensities that is suggestive of swirl sign. This is called swirl sign. Indicates active bleeding. Okay, so when you see such hypodense areas, that is swirl sign, indicates active bleeding. You need to do early craniotomy. Preferential craniotomy should be done in these patients who are showing the swirl sign. So remember, epidural hematoma, we'll do craniotomy, right? With the evacuation of the bleed, we do a craniotomy or a burr hole, and we do evacuation, surgical evacuation of the bleed. So whom should we take first? If you're having 2-3 patients, and whom should we take first into the neurosurgery department? I'll see the swirl sign. The one showing the swirl sign indicates there is active bleeding, there is high risk of herniation. I'll take him for a preferential craniotomy. If I see hyperdense sylvian fissure, basal cisterns, interhemispheric areas. So if the sulcal spaces are hyperdense, the sulcal spaces are white. So if the sulcal spaces, sylvian fissure, basal cisterns, interhemispheric area are white, this is an acute subarachnoid hemorrhage. This is acute subarachnoid hemorrhage. And if you see a crescentric collection, concavo-convex, crossing sutures, this is the right acute subdural hematoma. On this side, also you see a crescentric collection, concavo-convex, crescentric, concavo-convex, crossing the sutures. The frontotemporal suture is being crossed. So this is again a subdural hematoma, but here it is darker. So this is chronic left subdural hematoma. Please remember, acute bleed is hyperdense, white. Chronic bleed is hypodense, dark. So how do I differentiate whether it is an acute bleed or a chronic bleed? Acute bleed is hyperdense on CT. Chronic bleed is hypodense on CT. Acute bleed is white on CT. Chronic bleed is dark on CT. Acute bleed is hyperdense on CT. Chronic bleed is hypodense on CT. Now look at this CT scan image. In the left putaminal area, you see a hyperdense collection. This is a left putaminal bleed. Left putaminal bleed. This is a hypertensive bleed. Usually, hypertensive bleed occurs in the putamen. Most common site of hypertensive bleed is putamen. This is intraparenchymal bleed, right? The putaminal bleed. And here you are seeing this hyperdense sulci. So if you see such hyperdense sulci, this is suggestive of acute subarachnoid hemorrhage. So there will be hyperdense sulci. Hyperdense sulci. White sulci if you are seeing in a head trauma patient on a non-contrast CT, this is acute subarachnoid hemorrhage. But if you see this hyperdense collection within the ventricles, occipital horn of lateral ventricle, this is intraventricular bleed. Intraventricular bleed. So within the occipital horn of lateral ventricle, if you're seeing the collections, right, this is intraventricular bleed. In the sulcal spaces, if you're seeing the blood, that is suggestive of acute subarachnoid hemorrhage. So acute subarachnoid hemorrhage will be seeing collection in the sulcal spaces, sylvian fissures, that is acute subarachnoid hemorrhage. And if you see in the ventricle, that is intraventricular bleed. Okay. Now look at the CT scan in a patient of hemiplegia. So this is a case of right side hemiplegia, and you are seeing this CT scan image. The entire CT was normal, but at the level of the sylvian fissure, you are seeing the middle cerebral artery. Okay, in the left MCA, you are seeing a hyperdense area. So white area, the middle cerebral artery is appearing very white. It is in the sylvian fissure. So this is called as hyperdense MCA sign. Hyperdense MCA sign. Hyperdense MCA sign is a sign of acute infarct. Okay, this is suggestive of acute infarct. Hyperdense MCA sign is a sign seen with acute infarct. That means there is a thrombus inside the middle cerebral artery. Right, that is what the sign tells you. Hyperdense MCA sign, suggestive of acute infarct. Now look at this case of trauma, and you are seeing this hypodense area anterior to the frontal lobe appearing like a mountain. This is called as a Mount Fuji sign. Mount Fuji sign. And this is suggestive of tension pneumocephalus. Tension pneumocephalus. Right? And look at this case of right side hemiplegia. And the CT scans, they show you hypodense areas involving the anterior cerebral artery and the middle cerebral artery territory. The left ACA and the MCA territories, they show these hypodense areas. That means where is the thrombus? The thrombus must be in the left internal carotid artery. So by looking at the arterial territory, you should think where the thrombus could be. This is a left internal carotid artery thrombosis causing hypodense area in the left ACA and the MCA territory. So by looking at the CT scan, you should know where the thrombus could be. Now look at this image. Where do you think which artery do you think is affected? Right side or left side? This is right side. And ACA, MCA or PCA? This is the ACA territory, the medial aspect of the brain. This is the ACA territory. This is the MCA territory and this is the PCA territory. So this is a wedge-shaped area involving the right MCA territory. This is right MCA infarction, MCA infarction. So infarcts, these are hypodense on CT. So infarcts, they can appear hypodense and the hemorrhage will appear hyperdense. You saw hypertensive bleed, putaminal bleed, the hemorrhagic strokes, they will be hyperdense. Whereas infarcts, they may be hypodense or sometimes the CT may be normal, showing you the hyperdense MCA sign. So think of infarct as something that is appearing dark or hypodense on CT or can appear normal also. And sometimes you see small hypodense areas in the region of the basal ganglia. Think of them as lacunar infarcts. If you see small areas, those would be lacunar infarcts, right? Now look at this image. This is a case of right side hemiplegia. And you look at the CT scan is completely normal. I don't see any hemorrhage, I don't see any infarction. But when I do a diffusion weighted MRI is a special sequence of MRI we advise to our patients. Diffusion weighted MRI. You are seeing that there is a light bulb like shiny bright area in the left MCA territory. So this diffusion weighted imaging is the most sensitive investigation to look at acute infarct. So this is usually advised to look at acute infarct. You are seeing this in a left MCA territory. Diffusion weighted imaging is the most sensitive investigation to pick up acute infarcts in your patients. Now look at some anatomy on the CT scan. I told you, when you look at the CT scan anatomy of the thorax at the mediastinal vessels, this is the anterior, this is the right side, this is the left side, this is the posterior side. On the right side, anteriorly, you are seeing the ascending aorta, posteriorly the descending aorta. To the right of ascending aorta, you can see the superior vena cava. To the left, you are seeing the main pulmonary artery, right? So this is how you have your blood vessels in the mediastinum. You're also seeing the main pulmonary artery dividing into right pulmonary artery and the left pulmonary artery. And when you look at the section of the heart, below this, there will be section of the heart. Then you will see the most anterior chamber as the right ventricle, most posterior chamber as the left atrium. The most anterior chamber of the heart is right ventricle, the most posterior chamber is left atrium. And these are your pulmonary veins, which are opening into your left atrium. So the right ventricle, the left atrium. The atria, they lie posterior to ventricles. So once you identify the right ventricle and the left atrium, you can easily identify the other two chambers also. The atria are always posterior to their ventricles. So you can identify these chambers on the CT scan. And what do you think is this window? Is it a bone window, mediastinal window or lung window? You can see the bronchovascular marking and all nicely. This is lung window. And in the lungs, how do you know which is upper lobe, middle lobe and lower lobe? You look for these fissures. This bilaterally, symmetrically, this thin fissure is your major fissure. And only on the right lung, this thin fissure is the minor fissure. So this is the right upper lobe, this is the right middle lobe, this is the right lower lobe. Do not confuse right side, left side. This is the left upper lobe, this is the left lower lobe. That is how I know where is the pneumonia. Is it in the upper lobe or lower lobe, right side or left side, right? By knowing the anatomy. So remember this thin fissure that is bilaterally symmetrically present, that is your major fissure. And look at this CT scan. In a case of trauma, in the left side, you can see this hypodense area, which is not having any bronchovascular marking and which is also causing the visceral pleura to be separated and the lung to be collapsed towards the hilum. So this is suggestive of pneumothorax. So this is how left pneumothorax would appear. And what is this CT scan showing? This is showing a lung window. And what do you see here? Multiple signet ring-like opacities. These are suggestive of bronchiectasis. Bronchiectasis. And if you see, the heart is also more towards the right side. There is dextrocardia. And this patient also had sinusitis. The frontal sinus, maxillary sinuses were also opacified. There is also sinusitis. What comes to your mind when you see all of this? This must be Carter-Jenner syndrome. Cartagena syndrome. So please remember this signet ring appearance, okay, a bunch of grape appearance, signet ring appearance, think of bronchiectasis in your patients. This is the labeled anatomy of the abdomen, CT abdomen. You can see here, this is the pancreas, this is the liver on the right side, the gallbladder, the spleen, this is the right kidney, this is the left kidney. You can see this is the inverted V shape or triangular structure. These are your adrenals. This is how adrenal glands will appear. Adrenals, they are inverted V shape or triangular structure. Coming to the blood vessels, this vessel between the right and left crusts of diaphragm, this is the aorta. To the right of aorta, this is the vena cava. Just behind the pancreas, just behind the neck of pancreas, you see this vessel, this is the portal vein. So you should know which is the aorta, vena cava and portal vein. Between the right and left crura of diaphragm, right, that is your descending aorta. To the right of aorta, you should know which is right side. To the right of aorta is the vena cava. Just behind the neck of pancreas is the portal vein. So that is how we identify the different structures on CT abdomen. Now look at this image. Is it CT or MRI? Look at the bone. This is white. The vertebra are white. So this is CT. Now is it plain CT or contrast CT? So for that, look at the aorta, compare it with the surrounding muscle. The aorta is white. This is contrast enhanced CT scan. Contrast enhanced CT scan. Then if you see the contrast inside the bowel loop, this is a oral contrast that is given. If you see contrast in the blood vessels like this is IV contrast given. So this is a case where you are having both oral and IV contrast study done. Right, both oral and IV contrast is being done. Now look at this CT scan. Anterior to the liver, you are seeing a dark area of air there. This is how you see hollow viscous perforation on pneumoperitoneum. Pneumoperitoneum. Now please remember, air will always come upward, fluid will come downward. Air will come upward, fluid will come downward. So if you are having pleural effusion, you are having empyema, they will usually be on the lower part. But when you're having pneumothorax, when you're having pneumoperitoneum, on a axial CT scans, when you're seeing the pneumocephalus, pneumothorax, pneumoperitoneum, you'll see them on the upper part. So that is how you need to understand that air will come upward. So this black area anterior to the liver on an axial CT of the abdomen, think of pneumoperitoneum. And please look at this CT of the liver. Now this is a plain CT scan. You can see the aorta not having contrast. It is similar to the surrounding muscle. There is some wall calcification, but the aorta is not having contrast. Look at the liver. The liver shows lot of nodularity, right? Lot of irregular nodularity. This is suggestive of cirrhosis of liver. And you can see the surrounding fluid also. There is ascites in the patient also. That is how the CT scan would show cirrhosis and ascites. So if you see such ill-defined hypodense areas in the liver, in a case of cancer, think of liver metastasis. Right, so liver mets also, these will be ill-defined hypodense areas scattered in the liver. This is how you have secondaries or liver metastasis. And if you see a multiloculated appearance, septate appearance, multiloculated septate lesion, think of hydatid. Your amoebic and pyogenic liver abscess are unilocular, right? They will be unilocular cavity, amoebic liver abscess or pyogenic liver abscess. But if you see a multiloculated septate lesion in the liver, think of hydatid. Now look at this. This is a contrast CT scan done in a case of abdominal trauma. And what do you see here? You can see this is the liver, this is the spleen. On the right side is liver, on the left side is spleen. And you're seeing some fluid around the liver and spleen. But which organ do you think is injured in this patient? You are seeing the contrast blush coming from the spleen. So when you see such contrast blush from the spleen, think of splenic injury. So to know the organ of injury in blunt trauma abdomen, to know the organ of injury, it is not the ultrasound or the non-contrast CT that tells you the organ of injury in blunt trauma abdomen. In blunt trauma abdomen, to know the organ of injury, you have to do CECT. From wherever the contrast is leaking, that is the organ that is damaged. If it is leaking from the liver, it is hepatic injury. If it is leaking from the spleen, that is splenic injury.